What does it mean to be called crazy in a crazy world? Listen to Madness Radio, Voices and Visions from Outside Mental Health, sponsored by peer-run support communities Freedom Center, the Icarus Project, and Portland Hearing Voices. Madness Radio can be heard on FM stations on the Pacifica Radio Network and is streaming, podcasting, and archived at madnessradio.net. Welcome to our new broadcast station, KBOO, in Portland, Oregon. Thanks for joining us today on Madness Radio. This is your host, Will Hall. Today our guest is Joanna Moncrieff. She is a senior lecturer at the University of College London. She's a practicing psychiatrist with the National Health Service and the co-chair of the Critical Psychiatry Network. Joanna is the author of the new book out in paperback, The Myth of the Chemical Cure, a critique of psychiatric drug treatment. She's widely published in medical journals in the UK and Europe, and she is also one of the editorial advisors of the publication by the Icarus Project and the Freedom Center that I authored, the Harm Reduction Guide to Coming Off Psychiatric Drugs. So thank you for joining us today on Madness Radio, Joanna Moncrieff.
Thank you. You're welcome.
Well, your book, The Myth of the Chemical Cure, a critique of psychiatric drug treatment, is really excellent, detailed a look from a medical perspective on how drugs work and the myths and misunderstandings about what psychiatric drugs are all about. And we're going to be getting into that, and especially focusing on bipolar medications and bipolar disorder, especially lithium. Tell us about how you got interested in having a critical perspective on drugs and psychiatric treatments.
Well, when I started working in psychiatric hospitals as a junior doctor, what struck me immediately is how drugs were absolutely central to the process of treatment. Almost everyone who came in as an inpatient, and most people who were seen as outpatients, were on at least one sort of medication, and most people were on numerous different sorts of medication. And from my perspective, an awful lot of it didn't seem to be making that much difference. It seemed to cause a lot of secondary problems, and yet other doctors had a completely different perspective and seemed to think it was wonderful and people were getting better and because of the drugs. So I was aware that there were very different points of view about drug treatment early on, and that made me want to go and find out more about it.
And so what were some of the things that you've discovered and write about in your book?
Well, one of the things that interested me was the history of drug treatment. And when I looked back to the beginning part and the middle part of the 20th century, it was obvious that drug treatment, although it was used, didn't excite as much attention and interest as it does nowadays. And people didn't really think that drugs were curing people. They didn't think that drugs were altering the fundamental underlying problem. And then from the 1950s, that started to change, and psychiatrists started to believe that the drugs they had really were affecting the underlying disorder and helping to reverse it and to bring people back to normal. And yet, there wasn't really any evidence for that change in point of view. So that's what I've been looking at in my book and in other papers. I've been looking at the evidence base for how we view psychiatric drug treatments today and what it is, trying to understand what it is that they actually do to people.
Now, I guess the first drugs that were introduced sort of most famously was Thorazine, and it's an antipsychotic, a neuroleptic antipsychotic, and the real innovation with Thorazine was that essentially it's a tranquilizer that doesn't put people to sleep. That's essentially why it's so useful in psychiatry. Is that right?
That's right, and what's interesting is that the first people who used chlorpromazine in psychiatry recognized this and wrote about this very clearly. They wrote about how chlorpromazine creates this neurological syndrome, some of them called it. You know, they're almost talking about how chlorpromazine creates a neurological disease.
That's the medical term for...
Chlorpromazine is the generic name for Thorazine. It was marketed as Thorazine in the United States and Largactil in the UK.
Ah, okay.
So when chlorpromazine first came into use, the psychiatrists who were using it were very clear about what it was doing, and they described how it was producing this abnormal neurological syndrome that slowed people down and created this state of psychic indifference without just sedating people and sending people to sleep like the old sedatives had done. The barbiturates, which were used prior to Thorazine, had just made people very sleepy. So people thought it was a great breakthrough, but recognized that what it was doing was creating an abnormal neurological state. It wasn't just reversing an underlying disease. But then gradually that idea changed, and people started to believe instead that it was an antipsychotic and that it was somehow reversing the processes that were leading to the psychotic symptoms.
They're basically still this tranquilizer, but it works more on the higher functions of the brain, and so people lose motivation. They become indifferent to what they're experiencing. I mean, I've been on antipsychotics. I was on Trilofan and Mellaril, which are some of the older drugs, and they were very much, I mean, I remember blacking out from when I was on Mellaril, just not having any consciousness at all, and then I remember just being very much like it was kind of like some kind of a vice or some kind of like a cotton or wool was on my mind, just totally sluggish and just was groggy and could not. But, I was wandering around and sitting and watching television and sort of being there in the hospital.
Yes, that's a really good description. And they also seem to slow people down physically and cause physical restriction. They slow down movement. I mean, essentially, the older antipsychotic drugs cause a mild state of Parkinson's disease. We know that if you give high enough doses, they cause obvious Parkinson's disease-like symptoms. People get very stiff. And what I think is happening at lower doses is that they're causing milder symptoms of Parkinson's disease, which is a slowing up of movement, a feeling of restriction, both physical and mental.
Very much like a tightening or a gripping of the body, and you see people who are on high doses, they look, and that's I think where the term the Thorazine shuffle comes in, because you have this kind of like very stiff walk because you're no longer free. Your muscles have been tightened up. And when you say Parkinson's disease, tell us a little bit about that.
Yes, well, Parkinson's disease is a neurological disease which is caused by a deficit of dopamine in the brain. There's not enough. The brain isn't producing enough dopamine, and we need dopamine for movement and for thought. And so people with Parkinson's disease become stiff, and their movements slow up, and they lose their facial expression. And their thought processes slow up eventually as well. And the antipsychotics block dopamine production, and therefore they're inducing an artificial Parkinson's type state.
And then when they became more widely used, that's when the idea of the dopamine hypothesis as causal for schizophrenia came in.
Yes. Now that hypothesis followed from some experiments on haloperidol, and haloperidol is a very strong dopamine blocker. And when it was identified that haloperidol was working by blocking dopamine receptors, then people leapt to the conclusion that the underlying cause of schizophrenia must be overactivity of these dopamine receptors or the dopamine system. So there was an assumption that the drugs must be working by curing the underlying problem, whereas what I've been trying to say is that it's obvious that they produce this artificial state of, as you've described really well, this state of restriction.
And it sounds like previously to the introduction of the psychiatric drugs, there were much more psychological understandings of what schizophrenia is all about, and then the drugs sort of ushered in an era of seeing things strictly in terms of chemical imbalances and biological disorders of the brain and such.
Yes, I think prior to the 1950s, there was a social psychiatry movement. Psychoanalysis was very influential in the United States. But there's always been a tendency within psychiatry to want to find biological causes and biological explanations for mental disorders. So that's always been there, but it was given a really great boost by the introduction of these drugs, because psychiatry could then present itself as having medical treatments the same as the rest of medicine. It could present itself as doing the same sort of thing, giving people drug treatments to treat specific conditions, supposedly.
So when these neuroleptics were introduced, and then there was this theory that was developed that dopamine was the problem behind why people had schizophrenia, that became really widespread in psychiatry and kind of became the ruling theory about what schizophrenia is all about. Now today, Is that still believed, or because there's been a tremendous amount of research that's never been able to show that that's actually the case?
People in the psychiatric community, psychiatrists and researchers, again seem quite convinced that there is a dopamine abnormality underlying the symptoms of psychosis. Even though, as you say, there's an awful lot of negative evidence, the positive evidence is completely inconsistent, and even evidence that's quoted in favor of it, like the idea that stimulants, people say that, we know that stimulant drugs like cocaine and amphetamine cause psychosis, and because they stimulate dopamine, therefore psychosis must be caused by dopamine. But in fact, when you look into this, stimulant drugs like amphetamines affect numerous neurotransmitter systems, numerous brain chemicals. It's not just dopamine they affect. And so we don't even know that stimulants-induced psychosis is attributable to dopamine, let alone other episodes of psychosis.
So essentially the idea that there's a biochemical imbalance behind schizophrenia really came looking backwards on saying, well, these drugs seem to be working, so therefore it must be the drug action dealing with the underlying disease, but in fact that's not what's going on.
Yeah, that's exactly what happened. So the theory is already based on an assumption that if the drugs do something, they must be curing a disease. They must be working on the cause of the disease, the cause of the symptoms. And I often give, when I talk about different ways of understanding what psychiatric drugs do, I often give the example of alcohol and social anxiety. That we know that alcohol can be helpful for people with social anxiety, but that's not because they have an alcohol deficiency. That's because the state of intoxication that alcohol produces is characterized by a bit of social disinhibition, which can be useful if people are very socially anxious. But it doesn't say anything about the cause of the anxiety, the original cause of the anxiety.
Yeah, this is something that we talk about in the Harm Reduction Guide to Coming Off Psychiatric Drugs, and you discuss in detail in your book that actually this idea that there are recreational drugs on one hand and then they're way different, there are pharmaceutical psychiatric drugs on the other, and we actually don't even like to call those drugs, we call them medications, that the action is completely different. But what you're suggesting is that just like alcohol has a toxic effect, and so it causes chemical changes in your brain, gives you an intoxicated experience that for some people might be useful for them in, say, a social anxiety situation at a party or dealing with crowds or meeting people. The same kind of dynamic takes place with psychiatric drugs, that they change consciousness, they intoxicate you, they work in similar kinds of mechanisms of disrupting brain chemistry, and then the effects may or may not be useful based on the intoxication. Is that a fair way of kind of assessing this?
Absolutely. That's a very good way of putting it. I think that we should think of psychoactive drugs as including all the drugs we use in psychiatry and recreational drugs, and there's no fundamental distinction between them. What I often say, there's no fundamental distinction between the drugs we use in psychiatry, like antipsychotics and antidepressants, and the drugs that people take for recreational purposes, like alcohol, cannabis, stimulants, etc. What I often say, though, is that people take recreational drugs because they have nice effects, they make people feel good. Most psychiatric drugs don't make people feel good, they make people feel quite bad. But that doesn't mean that they're not having psychoactive effects. They're just they're producing a different sort of state, which most people don't like that much.
Yeah, and we also know that with the recreational drugs, a lot of times people are taking them for emotional, psychological, social coping. So they're kind of like they're medicating themselves or allowing themselves to be productive or effective. But the difference, of course, is that in psychiatry, you have this huge institutional authority machinery that's saying, wait a second here, there's this underlying disease and disorder, and the medications are treating it or dealing with it.
As you're saying, the thing that I think we're doing wrong at the moment is we're not understanding psychiatric drugs as drugs. We've got to understand them as drugs, as chemical substances that are alien to the body, that create an artificial state. It might be useful to take them, but whenever you take a drug of any sort, there are all sorts of dangers and hazards, And we need to treat them with that sort of, with respect. We need to understand them, understand what sort of effects they have, in order to be able to use them wisely.
And you describe this perspective as the drug-centered approach, and what psychiatry has historically been doing is a disease-centered approach. And so actually there isn't a lot of education or research on how the drugs affect you in general. It's more focused on, well, how does it affect so-called schizophrenia as a disorder or a disease, or so-called bipolar disorder?
That's right, absolutely, yes. So we haven't understood these drugs properly. There are lots of things that these drugs are doing that we don't know very much about, because we haven't looked at them as drugs, because we've just been obsessed with, do they alter the dopamine receptors, or do they, do antidepressants raise your serotonin levels, instead of looking at all the other things they're doing and what consequences all those effects have.
Do you think that's one of the reasons why the negative effects of these drugs is so underplayed and overlooked in psychiatry, and it's considered just a part of the cost of treating a disorder or treating a disease?
Yes, absolutely. So what's happened is that instead of seeing psychiatric drugs as drugs, they've become treatments. And by becoming treatments, psychiatrists are then able to focus on the supposed disease and the benefits of the treatment, and all the negative aspects of using a drug get put into the small print, get shoved aside and obscured.
Let's talk about bipolar disorder specifically, and some of the research and insights that you have into these treatments that are given, and very much the message that I've talked to so many different people in my work with the Freedom Center and the Psychiatric Survivor Movement, and now as a counselor, and they are just getting a message: you have bipolar disorder, that your mood swings are part of an underlying problem in your brain. You were born with it. It's who you are, and therefore you need the treatment. And what I'm seeing a lot is that people are really terrified, and one of the big messages is you need these medications, because if you don't take them, not only will you have another episode, but you could end up dying from suicide.
There's some really frightening stuff out there, and I was looking at a leaflet on this yesterday from the Royal College of Psychiatrists, which was suggesting that if you don't take treatment, you're going to have more frequent episodes. Now, I'm not convinced that that's been soundly shown. There aren't that many studies, long-term studies of how many episodes people have, and the pattern of episodes seems to be very, very variable, actually. And the other thing that's happening with bipolar disorder at the moment is it's changed over the last 10 years. When I first went into psychiatry in the early 90s, there was a thing called manic depression, and this was a very rare condition in which people had severe episodes of mania or depression that lasted for several months at a time, and the rest of the time they'd be fairly normal. And now the idea has come about that actually there's many more people who have sort of milder versions of this, and that you can have bipolar nowadays if you have mood swings, if your mood changes from day to day or from hour to hour. And so what it seems to me that's happened is that many more people who have ordinary emotional fluctuations are being diagnosed as having bipolar disorder and being put on potentially very toxic drug treatments for it. And one of the problems with this is that the research into the effects of drug treatment has only been done with this small group of people who have this much more severe and obvious disorder. And we don't know whether any of that research translates to the wider group of people who have some emotional fluctuations.
Now, historically, the treatment for bipolar disorder, and this is still true today, is lithium. Can you tell us about that? Because lithium has a really interesting history. I think it was actually an ingredient in 7-Up at one point. The soft drink 7-Up had lithium in it at one point.
Yes, lithium's very interesting. There was a fashion for using lithium in the 19th century because it was thought to help with stones and gout. There was a lot of doubt about it in the 19th century and a lot of concern about it, and it was thought that lithium might dissolve the crystals that cause gout, and it might was thought that it might also dissolve kidney stones. And it was found not to do this, but it still continued to be sold and marketed for this purpose. And one of the reasons that I think that lithium got taken up by psychiatry was because it was available in the hospital pharmacies because of this previous history of its use. And so when this man, John Cade, experimented with it in Australia, and then Mogens Schou, the Danish psychiatrist, started using it in Denmark, they were able to convince people to use it because it was there in the pharmacy and there was a history of using it. Because otherwise, I think it would have seemed like quite a bizarre idea. It's an alkali metal and it's very toxic, and it can easily kill people, and that's why people who take lithium have to have blood tests and have to be very careful not to take too much. And the interesting thing from the point of view of what we're talking about is that when people started to suggest that it might be useful in psychiatry in the 1950s, they were very much suggesting that it was a specific treatment for manic depression. No one thought about what psychoactive effects it might be producing. But it's quite obvious from volunteer studies that it has these sedative effects. It dampens down the nervous system. It slows up thinking, slows up reaction times, makes you feel very groggy, possibly also reduces creativity and spontaneity. And so, of course, it's going to slow people down a little bit if they're manic. But that doesn't mean it's a specific treatment at all. It's going to do that to anyone.
So it doesn't have a targeting effect on some bipolar mechanism in the brain, just like the antipsychotics don't have a targeting of psychotic mechanisms. They just have this tranquilizing effect that will actually affect anyone that takes them.
I think that the effects that we know that lithium has in normal people are, easily able to explain the effects it has if you give it to someone with mania or bipolar disorder. I don't think you need to have any additional explanation. No one's come up with a credible theory about what it might be doing in manic depression that is specific in any way. There are various speculations that it might be stabilizing the cell membrane or correcting electrolyte imbalances, but nothing concrete has ever been found or even proposed really that makes sense of that.
When people are prescribed lithium, they're put on a regular dose for long term, and the idea is that it's going to prevent future episodes, again with this fear in the background, because often it's a really catastrophic event. You have an incredible manic episode, you have this altered state of consciousness, you lose your job, it's incredibly shameful, and then the terrifying experience of going into the hospital, and then there's the fear of suicide. And so people are told, look, you need to be on this long term to prevent going back to that crisis. What about that aspect of it?
I think you're absolutely right. I think manic depression is a very frightening condition. And I think what's happened is that lithium and other medications have been held out as a magic bullet for this frightening disorder. And of course people have wanted to have something that they could pin their hopes on. The trouble is that the research that has looked into whether or not lithium helps to reduce the risk of relapse has lots of problems, and the main problem it has is that what these studies have done is they've taken people who've been on lithium for a long time already, and then they've randomized half of them to stay on the lithium and half of them to have their lithium stopped. And it appears that if you stop your lithium, especially quickly, that's such a shock to the body that it can actually precipitate a manic episode. And so a lot of these studies that are supposed to support the value of taking lithium long term are probably simply showing that if you stop lithium, you get into problems. And because of that, if we're starting lots of people on long-term lithium, we're storing up lots of potential problems unless people take it forever. If they ever stop it, they're more likely to have a relapse than they would be if they'd never gone on it in the first place.
So many people are told that when you have a crisis, that it's your underlying disease, your underlying disorder is coming back. And then actually, for a lot of people, it's the medication withdrawal. They've missed medication, they stopped their medication, and the rebound, the withdrawal effect is what leads to a psychotic episode as a result of the medication, not some underlying condition that they had before.
Yes, well, I think that's the case in some circumstances, and it seems to be particularly true after stopping lithium. I think there's a tendency as well for mental health service staff in particular to blame everything on stopping medication or reducing medication. So if there are any problems, if someone's experiencing problems and there's recently been a change in the medication, it's always, oh dear, they need to put the medication up again, or they should never have stopped it. And that makes it incredibly difficult for people to get off medication.
That the medication is protecting them from the underlying illness, and therefore they should really stay at a dosage that's going to keep things under control.
Yes, everything that happens after someone's stopped medication or reduced medication is attributed to the illness. People don't take into consideration very much anyway the possibility that there might be a withdrawal effect.
And there hasn't been very much research on the withdrawal process and the coming off medication process, is that right?
No, very little. There was some research done by a group in America on lithium withdrawal and antipsychotic withdrawal and how that could increase the risk of relapse of psychosis as well, but that group seemed to have stopped researching that area now.
And this is one of the points that you make in your book, The Myth of the Chemical Cure, that we need a drug-centered approach that looks at all the different effects that different psychoactives have, including the coming off process and what's the best way to support people and the best way to do it. Tell us about the mood stabilizer drugs, which are now used in addition to lithium for bipolar disorder.
Well, the mood stabilizers refers to any drug really that's prescribed for someone with bipolar disorder, and that now includes a group of quite different medications. So you've got lithium on one hand. You've got some antipsychotics are being promoted nowadays as mood stabilizers, i.e. as treatments for people with bipolar. And then the other group of drugs that are used are drugs that started life as anti-epileptic medications and are now being promoted for the use with mood stabilizers. And that idea came about in the 1980s. Someone thought that maybe manic depressive episodes were similar to epilepsy, and therefore it would be a good idea to use anti-epileptic drugs. Of course, they're all very sedative, like the antipsychotics and like lithium, so they probably have similar sorts of effects.
So these anticonvulsants, the anti-epilepsy drugs themselves are psychoactive, and they have a tranquilizing effect, just like the lithium does in the antipsychotics. And so someone just decided, hey, let's try them for people who are diagnosed with bipolar.
That's absolutely right. And the concept of a mood stabilizer is very misleading because none of these drugs have been shown to stabilize, to stop mood fluctuations or reduce mood fluctuations in normal people or in anyone. They don't do that. They're just sedative drugs. And the evidence base for their use are some studies that show that possibly they might reduce the risk of relapse in people who have manic depression or the most severe form of bipolar disorder. That's what they've supposedly been shown to do, although, as I said, like with the lithium studies, there are problems with those trials. But it's on the basis of those trials that they're being claimed to be mood stabilizers. But the name mood stabilizer, it seems to me, is very misleading because it implies a drug that will help to even out mood fluctuations, and that's not what they do.
If you are just tuning in, this is Madness Radio. We are speaking with Joanna Moncrieff. She is the senior lecturer at the University of College London, a practicing psychiatrist, and the author of The Myth of the Chemical Cure, a critique of psychiatric drug treatment. Is there any research that taking lithium or taking these anticonvulsant drugs actually lowers the risk of suicide?
There are a lot of people claiming that at the moment. There are some academic psychiatrists claiming that lithium in particular reduces the risk of suicide. In my opinion, these claims are based on very flawed studies, and these studies are flawed because what they do is they discount anyone who stops lithium. So anyone has problems with lithium or is possibly going into a deep depressive phase and stops taking it is immediately discounted from the figures. So they're actually only looking at people who are doing quite well and are able to keep taking their lithium over a long period. And therefore I don't think they're really giving a fair estimate of suicide rates. And then there were also some studies that show quite high rates of suicide in people who take lithium. There's one from the 1980s, a British-based study, quite a large one, that shows quite a raised rate of suicide in people taking lithium.
And there's a potential role in drug withdrawal itself in being a factor in suicide.
Yes, well, there is a bit of research showing that as well. It's showing that possibly there's an increased suicide rate after stopping lithium.
One of the things that we mentioned before is that lithium was very popular in kind of these patent medicines in the early part of the 20th century, and I had mentioned that it was in 7-Up and beer, but it's really very toxic chemical. People sometimes say, well, it's a salt, it's a natural salt, but it's actually quite dangerous. What are some of the toxic effects that people can get?
The toxic effects are severe neurological suppression, really. So people become very sedated and confused and very slowed up, and they get a big tremor, and then it also has an effect on the kidneys and the gastrointestinal system. So people also start vomiting and have diarrhea. So those are some of the symptoms. And one of the points I'm been trying to make is that the supposed therapeutic effects of lithium are milder manifestations of those toxic effects. So when you get toxic from lithium, when you've had an awful lot of lithium, you get confused and very drowsy. When you've had just a bit of lithium, you get rather sedated and slowed up.
Yeah, I've met a number of people over the years who have had kidney transplants as a result of lithium long term.
Yes, it can have quite severe effects on the kidneys as well.
I think you wrote that an early psychiatrist who questioned the use of lithium for manic depression called it, quote, the treatment of the manic patient by lithium poisoning.
Yes, I found that quotation. That was interesting, wasn't it? So you see, there were people around who were saying that, who recognized that situation even then, but they were drowned out essentially by the enthusiasm of the people who suggested that lithium was a specific medical treatment.
One of the things that we're seeing today is this incredible rise in the number of children that are diagnosed as bipolar. I saw a figure that since 1996, there's been a 4,000% increase in the number of teenagers and children diagnosed with bipolar.
Horrific, isn't it? Thankfully, we don't have that situation in the United Kingdom, and I would hope that maybe it's slowing down in the United States, but I don't know.
Why do you think it's different in the UK compared to the US? Is it the advertising that we have on television with the pharmaceutical drug commercials? And
it's probably partly that drug treatments are a more visible part of the culture, but it wouldn't have been possible to market the drugs that are used for childhood bipolar disorder in television commercials because the drugs are being used off license in these situations. So it's not that medications are being directly advertised to children or to parents, but the idea of that it's acceptable to give drug treatment to children, that behavior problems can be diagnosed as a medical illness and treated with a drug. I suppose all these ideas have filtered into American culture to a greater extent than they filtered into British culture, although they're here too.
What kinds of things should parents do if they have children who seem to be having difficulties with mood or with behavior or being in school and they are not wanting to put them on medication? There
are other forms of help. I mean, up until fairly recently, most of these problems in the United Kingdom would be dealt with without drug treatment, and they were dealt with social workers and psychologists and people who would help to try and identify what the cause of the behavioural problems were, and sometimes by linking up with schools and trying to identify if there are any particular issues at school.
And now there's more of a disease model, so the problem is no longer, say, something that's happening in the family or some emotional issue that the child is having that can be understood and grappled with, but it's a framework of the problem is in the kid's brain.
That's right. The problem's being located more and more in the child, and so people are looking less at the system around the child and how that might be impacting on the child to produce the behaviour behavior that's problematic.
Well, this brings us to an aspect of your work that I think is really interesting, which is that you described psychiatric medications as having an aspect of social control. Can you tell us a little bit more about that and how you see it fitting into some of the larger political issues here?
Yes, well, psychiatric problems consist of behavior that someone doesn't like. It may be the person who's showing the behavior who doesn't want to be behaving in this way, but it may be other people who don't like the behavior of someone close to them. And psychiatric medications are designed to try and change that behavior, and therefore they are about control. But the thing that is happening is that because they are called medical treatments, and because the behavior is given a diagnosis and called a medical disorder, that control is obscured and it's dressed up as medical treatment, as meds. And that means that it's easier to go to more extremes than you might otherwise go in changing behavior, because the therapists, the mental health service staff are not being held accountable for changing people, because it's assumed that what they're doing is in the person's interest because they're giving them medical treatment.
And when you say control, you're not necessarily meaning that in an exclusively bad way. I mean, there are times when we do want to get ourselves more under control or get greater control of the situation, but it sounds like you're asking for greater honesty, like you were describing the difference between a disease-centered focus and a drug-centered focus. Let's be honest, these are psychoactive drugs. They change brain chemistry. They intoxicate us. And is that useful to us? Let's look at the benefits and the risks and the implications of having mind-altering substances in us. And so the control issue is something that also should be talked about more openly. Is that right?
Yes, absolutely. That's what I'm saying. I think it should be more openly debated, and it should be more democratic. If we're going to control people's behaviour, and I think society does need to control some people's behaviour sometimes. So it needs to control the behaviour of some of the people that we diagnose currently as having psychiatric problems. But we need to do that honestly and openly to make sure that we do not overstep the boundaries, that we do not go too far. And the trouble is, if it's dressed up as medical treatment, there's nothing to stop the system from really heavily drugging people and controlling people in a very authoritarian way for a very long time. And that's what I think happens to some people in the psychiatric system.
What do you think is driving this push for disease and medical framework for how to deal with people's behavior that is problematic?
I think there are a number of drivers, and I think one of the drivers is coming from government, and has been coming from central government for a long time, because it's easier to medicalize this set of problems and just say, okay, we'll just hand that over to a set of doctors to deal with, and we can forget about it. Then governments then don't have to deal with with what are some very difficult democratic questions about, what sort of behavior you're going to control and what not, what sort of means of control you're going to use, how far that's going to go. It's all about balancing up people's interests, and can be a difficult thing to do. But I think there's been a big push from the pharmaceutical industry as well. Another way that drugs are used for social control is they're used to medicalize problems that people might otherwise see in a social way. So if someone's unhappy about their life and about their situation, at the moment they are being encouraged to look into themselves and see themselves as being the problem. And the solution that is held out to them is, you must take an antidepressant or an antipsychotic for your bipolar disorder, whereas it might be better for them to actually look at their situation and identify what it is that's wrong, what it is that's making them unhappy. And if people were more able to do that, there might be a greater resistance to some of the social trends that are happening at the moment that make people's lives very difficult. What I'm trying to say is all this use of antidepressants in particular, and other drugs that are doled out often by general practitioners, is taking our attention away from social changes and social problems, social issues that are making life difficult for many people and essentially blaming the individuals.
Do you think that there's a connection between the rise in psychiatric drug treatments over the past decades and the continued changes in our global economy and the way in which there's more economic crisis and greater poverty and more inequality?
Yes, absolutely. I think that the increasing use of psychiatric medications is a symptom of increasing consumerism, really. The idea that it must be possible to buy a solution for everything, and that every aspect of life is marketable. You can make a commodity out of it and you can buy something to solve the problem.
I wanted to ask you about the DSM-5 that's coming out. There's a whole new set of diagnoses and a whole new Bible for what are considered normal and what are considered abnormal states of mind. What do you think of the new DSM that's coming out?
I mean, I know that the people who are devising it are trying to incorporate dimensional factors. So they're trying to get away from the idea that you either have this psychiatric disease or you don't, and look more at the sort of vulnerabilities and tendencies that people have, which sounds good in a way. I have two concerns about it. One is that I think that it won't really transform into practice, because at the end of the day, there's still going to be a pressure for doctors and mental health workers to stick labels on people for administrative purposes. And secondly, I have the concern that it might actually enable the pharmaceutical industry to push the boat out even more, and persuade more and more people that they have mental health problems that they need to take pills for.
So whether or not you have a bipolar disorder is not an either-or question, but it's more, well, if you have bipolar tendencies, you can take this medication, or if you have that side.
I think they're doing this partly to try and get away from labeling and the stigma associated with psychiatric labels, so they've probably got some quite good motivations there, but I have a concern that it may be that it may prove useful to the pharmaceutical industry, just as the move away from the idea of schizophrenia and towards this idea of psychosis has been quite useful for the pharmaceutical industry, and they've been able to, by getting away from the schizophrenia label, focusing on psychosis, they've been able to get a lot more people into the net of antipsychotic prescribing.
So there's a marketing push kind of behind that. So tell us a little bit more about that. I'm not sure. I mean, with all the criticism of the word schizophrenia, which is after all a 100-year-old term, there's sort of a push to use more psychosis as a term, and then there's a danger, of course, that spreads the influence of diagnosis.
Psychosis has become a popular term, and it's partly become popular because of people's dissatisfaction and dislike of the term schizophrenia, which is completely understandable. It's become a very stigmatizing and frightening label. But what's happened is that by using the term psychosis, there's been a push to get people into treatment earlier. This idea of early intervention in psychosis has become very popular, and that's been supported by the pharmaceutical industry. They've paid for a lot of journal supplements on early intervention and paid for various sponsored conferences on early intervention. And the thing is that it's much easier to give someone a label of psychosis and therefore give them an antipsychotic early on in the course of their problems, rather than maybe waiting a bit, as would previously have been done. The thing is that with the label schizophrenia, because it was recognised to be, potentially quite a stigmatizing label, psychiatrists were probably a bit more reluctant to use it, and that went along with a reluctance to start antipsychotics before they felt they really needed to. And so what's happened with the replacing schizophrenia with psychosis, or one of the consequences, is that it's made it easier, I think, to start people on antipsychotics early, and therefore to start more people on antipsychotics.
So ironically, by using a less stigmatizing term, you end up having more people getting the diagnosis and more people on medications. So it becomes a bigger market for the pharmaceutical industry.
I think that's what's happened, yes. I think the point about long-term treatment for bipolar disorder is that all these drugs that are recommended, like lithium and the anti-epileptics, Depakote and olanzapine, the antipsychotics, they're all sedative drugs. They may make you slightly less likely to have a manic relapse. They may do. The research is, I would say, is still not conclusive because of all these problems with the discontinuation design and people having withdrawal-related relapses. But they may do. Even if they do, if they reduce your risk of having a relapse a little bit, you might feel that a relapse is so awful that you want to go onto the drugs for years and years and years in order to get that benefit, but you might not, because being on sedative drugs for years and years and years isn't very pleasant, and all these drugs have other physical side effects as well. So I think that's the balance that people are looking at when they're thinking about long-term treatment for bipolar disorder or manic depression. And I think the problem is that if these drugs are sold as treatments, people get an unrealistic idea about their ability to reduce relapses. At the very best, as I say, they're going to reduce your risk of relapse a little bit. They're not going to wipe it out completely at all. And the consequence is that you're going to be you're going to be sedated for years and years.
And the long-term risks that has in terms of your body and cognitive changes and memory. And
yes, absolutely. Plus, you're going to be on a treatment that has, all of the current mood stabilizers have a wide range of severe physical side effects with long-term treatment. So I think it's a really difficult decision for people to make because, as you said earlier, manic depression, a manic episode is very frightening and can have huge, huge consequences for people's lives. And so, if there is something that substantially reduces the risk, then that might be a good thing. But we need to balance that up with the negative effect, and we don't really know whether they reduce that risk to a significant degree.
Yeah, and there are also the other aspects of alternative ways of dealing with a crisis or preventing a crisis that we talk about quite a bit on Madness Radio. And additionally, I think the fears are often exaggerated. I mean, people are just completely overwhelmed. Your personality changes dramatically, and then it's kind of like there's nothing we can do other than call 911, and hopefully people would have other ways of kind of addressing that rather than seeing psychosis and an episode as the end of the world and it's the worst thing that could ever happen to you.
That's right, and I think the way that drugs are presented for the treatment of bipolar disorder makes that fear worse, because it's presented that, if you don't take these drugs, you'll have another relapse, and if you do take them, hopefully you won't. And if you don't take them, the relapses will get more frequent, and you might commit suicide, as you'd say. All these really very frightening scenarios, which don't have a lot of evidence base behind them, are put to people.
One of the things that people are told is that there's a kindling effect, that the more you go without treatment, the more episodes that you have without medication, that your disease gets worse and worse and worse. So you'd better start medication early. Is there any research that actually shows that?
There is a Swiss group who have followed up a bunch of people with manic depression over a number of years, and their theory was that the episodes got closer and closer together. That research has been quoted very widely, and that is the basis for these claims that you need to take treatment, otherwise you'll have more and more episodes. But actually, if you look at the paper that's based on, that's not quite what they found. They just found that people who had a lot of episodes were more likely to have another episode. So that's not the same thing as saying that everyone has progressively more frequent episodes through the course of their disorder. And actually, if you look at other research, what you find is that it's very variable. Some people will have episodes of increasing frequency for a few years, but other people won't. Even people whose episodes get more frequent for the first few years, it then seems to space out a little bit after that. A lot of people, it seems to burn out in later decades. So it's a very, very variable condition.
That's one of the things that I've noticed as well, is that often it's other factors that can be cumulative. For example, if someone is chronically sleep deprived, or their nutrition is going downhill, or they're suffering from situations of poverty, or they get more and more isolation, yes, those can be cumulative over time, but that doesn't necessarily mean that there's a disease action that's taking place. Those are circumstantial and social kinds of factors.
And I think, as you said, that people can learn to get some control. I mean, I suppose what's so frightening about manic depression is it's completely out of your control. This episode just comes on and you have this change in personality, as you say. But I think people do learn to exercise some control over it often after a few episodes.
We are just about out of time. Joanna, give us the information about your book again, and also a way to contact you, and if there's a website for the Critical Psychiatry Network as well.
The Critical Psychiatry Network has a website. It's criticalpsychiatry.co.uk, and there are a lot of papers written by myself and other members of the Critical Psychiatry Network on that website, and other interesting articles giving an alternative view of psychiatry. My book is published by Palgrave Macmillan. It was out in paperback in the UK in September, and I think it's due out in paperback in the US sometime around now. The Myth of the Chemical Cure.
Joanna Moncrieff, thank you for joining us today on Madness Radio.
Thanks very much, Will. It's really nice to talk to you.
You've been listening to an interview with Joanna Moncrieff. She is senior lecturer at the University College in London, a practicing psychiatrist with the National Health Service. She's the co-chair of the Critical Psychiatry Network and author of The Myth of the Chemical Cure, a critique of psychiatric drug treatment. That's all the time we have on Madness Radio. Thanks for tuning in. You've been listening to Madness Radio, voices and visions from outside mental health. Madness Radio is co-sponsored by peer-run support communities Freedom Center, The Icarus Project, and Portland Hearing Voices. Hosted by Will Hall, music producer is John Rice, with technical assistance from Jeremy Lantzman. Listen to our internet stream, podcasts, and show archives at madnessradio.net. Madness Radio can be heard on FM stations on the Pacifica Radio Network, including KBOO in Oregon, WXOJ and WBCR in Massachusetts, Alaska's KWMD, and WPRR in Michigan. If you have an idea for a story or guest on Madness Radio, to help get us broadcast on a station near you, or if you just want to share what's in your head, contact radio@madnessradio.net.